Okay, good morning everybody. We are going to make a start. We're hoping that a few more people will join us as we go. So my name is Naylor. I'm the Director of Nursing here at Hospice Waikato, and I'm facilitating our TeleEcho Clinic today. I will just start by getting people to introduce themselves. Start with our people joining in. So Julia is first on my screen. Just unmute you and you can introduce yourself. Okay.
Hi, good morning.
Hey.
Can you hear me?
Yep.
Can Juliet.
My name is Julia Ford. I'm one of the ARC liaison nurses, currently in Pukoi, and maybe might be joined by some cats, possibly. Maybe a dog or a husband, I'm not sure.
Good, welcome.
Thank you.
And then we have Robin.
Hi. Hi from Gisborne. Can you hear me?
Yes, we can. Welcome back. We can't see you, but we can hear you.
Oh, that's the better part.
And I'll just come back to our table now and get people to introduce themselves. So, Gail, would you like to start?
Hi, I'm Gail. I'm the Spiritual Care Coordinator here at Hospice Waikato.
Good morning, I'm Jackie, and I'm one of the nurse educators here at Hospice Waikato.
Good morning, I'm Andrea. I'm the Education Coordinator at Hospice Waikato.
I already said hello.
Morning, my name is Dee Barham, Palliative Medicine Specialist here at Hospice.
I'm Brian Enns, the Medical Director at the Hospice.
Hi, I'm Charmaine, Counsellor, Family Services.
Good morning, I'm Madeline. I'm one of her rural CNSs and live in my office.
Maddie and Charmaine, can you move a bit closer because you're out of view? Thank you. Have you got the next slide? Just going to share our screen with a little bit of extra information. Hopefully. There's the next slide. Oh, there we go. The first I did have a couple of things. Just remember, if you are not speaking, just to keep your microphone on mute. We'll try and manage that from our end, keeping people on mute. And if you need to ask a question or want, just put your hand up, give us a wave, and we'll unmute you. Yes, Robin will be exactly the same. So we all mute and unmute.
We can't see your wave.
We can't. That's a good point.
Very good point. You can send a message.
You can, or you can actually unmute yourself. You just need to click on your mute, unmute button on your screen. The case study that we'll be presenting will be anonymised, so please, if you do happen to know the person, don't share any identifiable patient health information. We are recording today's session as well for educational purposes, so if you're speaking, please identify yourself and speak at the camera. I've said about muting. No one's listening by phone, so that's all right. Just for doctors who are attending this, our echo is endorsed by the College of GPs for CME. We're doing our meeting for an hour, so it'll be 1 CME credit. We do provide certificates for for everyone, but for other health staff who need to record their education hours, that'll be on the certificate as well. I just need to make sure that for the CME you've signed in and we know that you're here. And also, if you could please complete the evaluation form at the end of the echo, just so we know how we're doing. So our agenda for today is we've done some introductions. I'm going to present on the challenges of wound malodour. Then we have a case presentation by Dr. Ensor, and then we'll have some closing comments. So the case presentation, I think everyone here will be familiar with it. We present the case and you have an opportunity to ask questions or clarification. and then we get people to provide recommendations and suggestions or comments about the case as well. So we'll move into the presentation. So just see if I can control it. Oh yeah, good. So it's not a huge group of people here, but I'm actually presenting this next week at a conference, so it'd be good to get feedback on the content as well, and also I can see how long it's going to take, because I've only got 15 minutes next time as well. So wound malodour can be a particularly challenging problem, so that's why I've been asked to speak about it. We've had a couple of cases recently where this has been a challenge for us or for the patient that Brian's going to present as well. And just for your interest, I've been working on a book chapter on malignant wounds, and this is a particular issue with malignant wounds, so I've tried to find the most current evidence for managing wound malodour, and there's not a lot, so I'm going to present what I've found. There are some photos of human wounds in this presentation. I always forget to tell people when I'm doing a presentation on wound care that often there are some quite graphic photographs of some quite nasty wounds, so there will be some of those in this presentation. Hopefully, by the end of it, you will be able to describe the causes of wound malodour, discuss the impact of wound malodour on patient. You'll be able to discuss different options for managing wound malodour, and then identify the most appropriate treatment option for a patient when you come across them. So wound malodour is primarily associated with bacterial colonisation of necrotic tissue within the wound. Necrotic wounds usually contain multiple microorganisms and can be colonised by a wide range of bacteria, including aerobic, facultative, anaerobic and anaerobic bacteria. In particular, the presence of anaerobic bacteria is highly correlated with wound malodour. And essentially, as the bacteria break down the necrotic tissue, they release amino acids, organic chemicals, and in particular the polyamines putrescine and cadaverine. Yeah. Don't sound very nice. And volatile sulfur compounds and short-chain fatty acids, and they all are the cause of the unpleasant odour. Can be complicated if there is a fistula within the wound, especially if it has a connection with the bowel. And another issue can be dressings are left in place too long and they have stale old exudate sitting in an absorbent dressing, which can be smelly as well. So just a few examples. Dry gangrene, so gangrenous limbs can be quite malodorous, and usually it's again related to bacterial colonisation of necrotic tissue. Even though it might not be visible, there is always moist necrosis underneath the dry eschar. And that's where the bacteria lives. And just a point here that debridement of this type of wound is not recommended unless it's a full-on surgical approach. If you try and debride it using gels and things, you tend to make the problem worse by softening the necrotic tissue, increase the risk of bacterial colonisation, increase odour, increase risk of infection. So generally, if this, especially end of life, we just try and maintain the patient's comfort and maintain the odour using one of the options I'll talk about. This is a photograph of a very deeply ulcerating wound in a woman's groin from squamous cell carcinoma of the vulva, just showing the level of the volume of necrotic tissue, and because the wound is deep and it's irregular in shape, it can be quite hard to get a dressing in to that type of cavity and to get adequate coverage of a treatment for odour. This is obviously a very large and deep pressure injury with a large volume of necrotic tissue which is moist. So a very good environment for bacteria and likely, or this kind of wound would be very malodorous. And again, because it's very deep necrotic tissue, quite hard to treat because the bacteria will be in the deep tissue as well, not just sitting on the top. This is a quite an extensive abdominal wound. Sorry, it might be a bit hard to tell where that is. Patient's legs are at the bottom. This patient had multiple surgical interventions for initially a bowel resection and then several dehiscences of the wound. Ended up with this wound, which is sort of healing, but in the middle is a fistula that leads to small bowel, so a lot of quite malodorous and high volume exudate or effluent, coming out of that hole. So the strong malodor associated with necrotic wounds can be one of the most distressing problems for patients, as well as being a challenge for their caregivers and family and the healthcare professionals looking after them. Wound malodor is commonly overpowering, unpleasant and persistent, and it can trigger gagging and vomiting reflexes. And I have seen this in not even junior nurses, but some experienced nurses, and particularly related to fungating wounds. It has been suggested that the type of odour produced by fungating wounds, it may be similar to other wounds as well, doesn't lend itself to desensitisation. So in other words, neither the patients, caregivers or health professionals get used to the smell, even after they've been exposed to it for a long period of time. There's not a lot of literature on the impact of malodorous wounds on patients. There is a growing body of literature on the impact of chronic wounds. So this is taken from that. And then there's a little bit of evidence from fungating wounds as well, where people have looked at the impact on patients. So a major component of suffering with chronic wounds is related to uncontrolled symptoms of pain, bleeding, leakage and malodor. Patients feel a loss of control over their body. Malodor in particular has a devastating impact on the patient and their family and caregivers. Uncontrolled smell can lead to feelings of embarrassment and disgust and to depression. And the symptoms have a detrimental effect on the person's body image, their self-esteem, sexual expression, and that leads to significant social and relationship problems. Often patients with smelly, leaky wounds become quite socially isolated. In one study that looked at patients with malignant wounds, the participants in the study, I think who are primarily women with breast cancer, they described the wound as being the worst part of their cancer, as it was a visible and unpleasant reminder of their cancer and prevented them from living a normal life. So the control of these symptoms is really important because it can have a significant impact on a person's quality of life. So there are a number of options available for managing wound malodor, and they can be grouped into three different approaches. So removing the medium for bacterial growth, which is the main contributor to malodor, reducing or removing the bacterial burden, and containing or masking the odour. So I'm going to look at each one of these individually. So removing the medium for bacterial growth. So essentially that is removing moist necrotic tissue. So that can be done through selective debridement, taking away the malodorous tissues, reducing the medium for bacterial growth, and also reducing the bacterial burden in the wound as well. You have to be very careful if undertaking sharp debridement, conservative sharp debridement, due to risks of pain, bleeding, inadvertently damaging other tissue. So it's recommended that you only remove loose necrotic tissue, and you do that carefully. And really, there's a big push internationally, certainly in Australia and New Zealand, for health professionals to have undertaken training and a competency assessment in conservative sharp debridement before they pull out their scalpels and scissors and things. You can use autolytic debridement, so that's using usually a gel or an occlusive type dressing to encourage the body's own breakdown of necrotic tissue. Just need to be aware that often that can increase the amount of exudate, it may increase the volume of necrotic tissue, so it could initially cause an increase in odour. Often what you find is you need to do a bit of both. So you need to use autolytic debridement to soften the tissues, loosen them up, and then you can debride them using sharp debridement. So this is just another example of quite a large pressure injury on a patient's sacral area. In this case, it's not as big or as extensive as the last one, but it's going to be quite deep. But there's loose necrotic tissue there that could potentially be removed through sharp debridement. Potentially this person could go to surgery, but actually this patient was near end of life, so surgical intervention was not appropriate. But for a symptom management perspective, you could carefully debride some of that necrotic tissue and then move on to other options that are non-invasive or non-surgical. So usually what we do, and particularly in palliative care, is to try and reduce or remove the bacterial burden. And there's a few different ways of doing that. Most of them are topical treatments. The most common is this one, metronidazole gel applied topically to the wound. It does have a reasonable amount of evidence behind it to show that it is effective in reducing wound malodor. It's active against anaerobic bacteria, which are, as I said, primarily responsible for the odour. But when you put it on topically, you get a very high concentration, so it is effective against some other bacteria as well. Most commonly, we would use a 0.75 to 0.8% gel. The example I've got in the picture is commercially prepared gel. Applied to the wound, usually once a day, can be twice a day. Once a day is normally enough at the dressing change. You usually get a reduction in wound odour within 1 to 5 days. The commercial preparations like rosettes can be pretty expensive. I think it's about $30 a tube. So we often, and a lot of hospices will often get a local pharmacy to make up a topical mixture, which is also as effective as the commercially prepared stuff. Some people in the past have taken metronidazole tablets, crushed them and sprinkled them on wounds. That is not recommended. There is a particular wound care clinician in Australia, Jeff Sussman, who speaks about this quite regularly, that you don't, well, I mean, we know what's in tablets, but what was in a tablet is not necessarily good to put on a wound. So the commercially prepared or the compounded gels are better than sprinkling tablets on. The tablets do work, but it's just not a recommended approach because it's an oral tablet, not a topical treatment. If you have a deeply ulcerating wound or a particular fungating wound that involves a body cavity, then in the past I have used a low dose oral metronidazole as well, and particularly if there are signs of infection, it might be useful, and just to trial a small dose, 200 to 400 milligrams 3 times a day. 400 is the treatment, normal treatment dose, 200 is sort of a low dose. You just need to be aware of some of the side effects, although most of them are very rare, things like nausea, rash, confusion, and patients need to be warned about the alcohol intolerance if they're having metronidazole, and you need to be cautious in people with liver failure as well. There are a couple of new treatments I'll just mention. This is one that we've been using more often nowadays, superoxidized solution. In New Zealand it's marketed as microdacin. It comes in a liquid in a spray bottle, so you can use it to clean the wound rather than saline. And it also comes in a gel, so you can use that to apply to the wound surface as well. It's highly microbicidal. It kills a wide range of microbes. It has an anti-inflammatory effect. It's harmless to healthy tissues. The sales reps who market this like to spray it in their mouth just to prove the point. Essentially, it's a very dilute chlorine bleach solution. But it is effective. We here at Hospice Waikato have used it on a number of patients, and it does tend to work quite well. Very similar efficacy to metronidazole. There's no really good clinical studies yet on this product in wound malodor. The company has one paper, but it's not what I'd call highly scientific. The company also says that it inactivates the volatile molecules responsible for malodor as well. I presume that's through some sort of chemical reaction because it's a highly reactive oxygen species in the solution. And the price of this stuff is actually not that bad. It's about $16, I think, for the spray or the gel. And it is, while metronidazole is a prescription antibiotic, microdacin is a wound device, I think it's classed as, so it doesn't have to be prescribed. It's non-prescription. And again, we would just use that, clean the wound once a day and apply the gel if you want extra effect. Just actually one thing to mention, we have a few patients who find it stings when you spray it on. Not too sure why the company thinks that doesn't happen, but it does. We've had a couple of patients who said it's a bit stingy. The next product is, actually it's a bit of a combination. Polyhexamethylene biguanide, PHMB, is the main component, which is an antiseptic. In Prontosan, there are a few other products that have PHMB in. Prontosan also contains betaine, which is a surfactant, which helps in wound cleansing. So this is effective in reducing bacterial burden and biofilm. So it penetrates in biofilm and kills bacteria, reduces wound pain exudate because it has an anti-inflammatory effect and reduces bacterial burden. So again, you have a solution that you can irrigate the wound with. You can do a soak, so that's gauze soaked in Prontosan, put on the wound for about, I think they recommend about 10 minutes, and you take it off and put your dressing on. And they also have a gel, so you can put a topical gel on as well. And their recommendation, of course, is to irrigate the wound with Prontosan and liquid and then apply the Prontosan gel. So good for infected wounds, but also good for wound malodor. The only challenge with this is, again, it's not a prescription medication, it's a wound device, but it is fairly expensive. It's in the region of $50 to $60 for a big bottle, $30 odd for, I think, for a gel. It comes in packs of 4. So there are a few other things you can do. Although they don't have a lot of supporting evidence for wound malodor. One of those is silver dressings, which are microbicidal for a wide range of microbes again. The best ones are the ones that release silver into the wound rather than just retaining it in the dressing and killing stuff that comes with the exo into the dressing. Silver dressings are pretty expensive, so if you've got an extensive wound or you're changing it very frequently, it can be pretty expensive. Other options, sugar paste, not easily available these days, used a little bit in the UK, or wound grade honey, so that's easily available in New Zealand. Pretty expensive though, because it's the fancy Manuka honey, and you need one with a high UMF and it has to be wound grade. So it kills a wide range of microbes and it's anti-inflammatory as well. So if a patient wanted something more natural than microdacin, well, microdacin is a pretty natural product, it's just superoxidized water, but you can use honey. So containing or absorbing wound odour usually provides immediate odour control. Dressing products designed to achieve this usually contain activated charcoal, usually as a layer of charcoal cloth that attracts and binds the odour-causing molecules. Most of these dressings are designed to be secondary dressings, but there are a couple that are designed to go directly onto the wound surface, and some of those have other wound products as a part of the dressing, like an alginate or a hydrofiber. Essential oils can help to disguise the wound odour, can be applied to the outer layer of the dressing or used in a diffuser in the patient's room. And then just daily dressing changes, so you haven't got stale exudates sitting in the wound. I've included charcoal blocks and cat litter because I know this is, or has been, quite a common hospice approach, because in theory it absorbs the odour out of the air, but there's no evidence for using it. It's just anecdotal from practice. And if you do want to use that, you have to use the very high quality cat litter. The cheap stuff doesn't work. Just wanted to talk briefly about a case of a patient who I helped as part of the team look after when I was down in Wellington. This patient presented to the emergency department, was rapidly seen by a breast surgeon, and then was referred to oncology. And I got asked to go and see her when she came in for her first outpatient clinic appointment with her oncologist. And this is what she presented with: a very large fungating breast cancer, which had been present for several months. Oh, we've got a cat bum in the view. So although there's all these different options, the challenge is when you get presented with a wound like this, what on earth do you do? So she was in her outpatient department. The consultant couldn't stay in the room any longer than 5 minutes at a time because of the odour. The nurses and outpatients were panicking because the odour was permeating the whole department, and there was people in there having chemotherapy, other people in outpatient clinics, etc. So we had to do a number of things. One was immediately manage the odour, and then I got asked to come up with a plan how we were going to manage this wound, because she was also going to be going forward for chemotherapy. In fact, ended up having chemotherapy and radiotherapy. So taking into account all of those options, I ended up using most of them. So first thing, we had the nurses putting out some essential oil. In these days we had the burners, we didn't have the fancy diffusers, so we used, I think we had bergamot. So the citrus oils tend to be quite good for odours. So several of those were put around the department to help with the odour. And then the treatment of this wound, I did a very small amount of debridement. There was just a few loose bits of tissue on there that were easy to remove, but a high risk of bleeding, and it was very painful as well, so not too much. And then instigated a treatment regime of metronidazole gel topically once a day. And fortunately for this patient, she had a special authority approved, so she got sent boxes and boxes of Rosex, which was, $30 a tube. We're using one tube at a time. And then we had a layer of a non-adherent dressing, and then activated charcoal to try and get some immediate impact on the odour. And that was, then we had an outer pad, big combine dressing held in place with Surgifix netting vest. And that actually worked really well. It took a few days to get the odour under control. The district nurses were doing the dressings at home, yeah. So this patient and her husband wanted to do a lot of the dressings themselves, so we had to show them what to do. They did a pretty good job. But it was a big challenge, and the impact of the odour on everyone else in the department was quite significant. The poor nurses didn't know what to do to manage it. So that's me. I'm happy to take any questions if anyone has any.
Picture that you just showed, Wayne, how long had that lady had that wound for before she presented at ED?
Her history was a little bit tricky. She'd been treated by a GP who had not done any sort of diagnostic workup and had suggested that she tried an alternative diet. The GP had a bent towards complementary therapies. So she had originally gone for a small ulcer on the breast, and her breast had changed shape. I think that was in September, and then she came into ED in somewhere around January, February the following year. So probably it was 4 or 5 months from when she got to her GP to when she presented like that.
Thank you. Wayne, you didn't mention anything about anti-nausea. If people are quite nauseated because of the sniper triggers, is there any role for using anything orally to help manage the nausea secondary?
That's a good question, because I don't know, because the nausea is triggered by the smell. Yeah. So I don't know that anything would be affected.
Yeah, I don't know.
It's a good question.
Yeah.
Yeah.
I suppose you'd have to look at the where in the vomiting pathway that triggered. I don't know if anything would work on a smell type thing.
I guess something centrally acting may dampen down the vomiting centre, but I don't know if there's any evidence for it.
Yeah, good question. Should we just check? Robin, I'm just going to unmute you. Did you have any questions or comments?
No, other than that's very helpful. All those other products I've only been aware of metronidazole really. So I'll take that back to the team. The others might have more knowledge of the newer preparations. We see a lot of nasty wounds here. There's a lot of poorly treated lesions that get to a quite bad state, especially facial ones. We've had quite a few nasty faces to deal with, which are probably worse than anything else.
Yeah, we've had a bit of a run of those as well lately. So we've been using microdacin in particular on those. We have used metronidazole on a couple. One of the tricky things around facial ones is where they have it fungating into the mouth, and they can get a very unpleasant taste and the smell as well. And some people recommend a metronidazole mouthwash for that. And potentially, if you can do a oral or enteral metronidazole might help there too. Did you have any questions or comments, Julia?
Yeah, hi. I always travel with my.
Oh, it's getting a bit old now.
The way Naylor.
That's his photograph. Can we see?
That's how old it is.
It didn't change much.
It's very well lit. I guess thinking about the challenge in aged care, the impact of there's so many things that so much call on the nurses' time in aged care, and the cost of the things, the lack of understanding and fear maybe. In one facility back in the UK, they used to use those huge tea bags.
Yep.
Yeah.
Yeah, I have heard and seen. It's probably only been one article we ever published on tea bags, and it was just case stuff, not very scientific. Some people do it, and apparently black tea works better than green tea.
Yeah, this was black tea. It was NH black tea. So those really, really big tea bags, and I guess the belief was it did help with the perhaps the odour in the room. And I was caring for an Indian lady up in South Auckland, and they were doing the same thing, but with smaller tea bags.
Yep.
And somebody else put some bicarbonate of soda just in the room, just to try to help absorb, because it's quite good at absorbing smells.
Yeah.
Having cats. I know that's sometimes something you want to try to do. So, yeah, I guess the impact in aged care of this type of wound can be quite significant, and they do need a lot of support.
Yeah. Cool. Thank you. So just for your interest, I've included. There are some references on the slides, but it's all right. So we might now move on to the case presentation. We're 5 minutes over time, so we better move on to Brian. Thank you very much for bringing the case, and call this screen share now so you can take it away.
Thanks, Wayne. It is a story that is obviously familiar to Julia and perhaps most of us, and the picture that Wayne showed of the wound in the groin is just this scenario. So she's 98, and she presented with, I think, dysuria just over, a year ago, and diagnosed with a squamous cell vulval cancer, which had a bit of, which had an excision, and at that stage there was a little bit of nodal disease, but it developed into both perineal and this groin wound. The big story is it's going to be very familiar to us. An elderly woman living with her daughter. She has a dementia that's not too bad a year ago, but has been developing, and she's prone to falls, to dehydration, to renal impairment. The big admission was this one a couple of months ago, where she was admitted into Waikato with confusion, falls, incontinence, and it was felt for various reasons that she could no longer stay at home with her daughter, and she shifted into age residential care. So it wasn't the wound particularly that took her into hospital, but in age residential care, it was the wound that was the most problematic. Flick it up a little bit and we'll just talk, no, when I say up, I mean down. Yeah. Yeah. So this was a wound that was, if I've got the dimensions there, it was a bit bigger than that picture. It was sort of 6'5" by 5 or something like that. I haven't written it down. A reasonably substantial wound, and she came out of hospital on augmentin, but it was very smelly. But for the staff, it was actually having to dress this wound each day, and we were called because they were struggling to do it without a lot of distress on the patient's part, who would yell and hit out at them when they were trying to do this wound. Every second day they took the dressing off in the shower, and that was helpful, but they didn't have the time to shower this dressing off every day, and so otherwise they would have to do it de novo. In hospital, they gave her 5 milligrams of morphine a couple of hours before cares. They had put her on a Norspan patch, and they had put her on an antibiotic, which I'm not sure if that was for the wound or for the urine tract. I didn't have a lot of confidence in terms of helping this this woman. I know that traditionally hospice has used a pre-med of opiate and midazolam, and they weren't using midazolam. I think the GP had changed it from morphine 5 to oxycodone 5. It's their pre-med, which didn't seem to be particularly helpful. And so the story really is working a little bit in the swamp and trying morphine and midazolam. What did we, a bit of a discussion about starting high or low in terms of 2.5 or 5 milligrams, and electing to start a bit high to see if we can just get it to sleep. And after a while, hopefully, as the nurses built their skills and the patient built their tolerance, we could do it under less midazolam cover. The wound was very painful, and it was this thing, is it infected or is it? It was very painful, and is infection part of that? And we put her on metronidazole orally. And then there was this question of helping in the actual dressing so that it wasn't sore. And I've been to a pediatric course about distraction and wound pain for children, in ED, and the idea that you can actually treat a child without pain when they come in for their sutures and all that sort of thing. And whether we can use distraction in the elderly is an interesting thing. We used to have buzzy bee. Do you know what I mean by a buzzy bee? A vibrating tool that looked like a buzzy bee that you put in proximally to the wound, which was supposed to provide a bit of pain relief. I'm sort of interested in whether people think that's a current idea. And then we also put lignocaine in the wound, which was it's a little bit contentious, and even more so because the only lignocaine available was for urinary catheters, which also had chlorhexidine in it. And so we ended up giving her oxy and midazolam, and then waiting for a while and soaking the wound off and putting lignocaine gel with chlorhexidine into the wound, and then waiting a while and then cleaning the wound out. And I'm not sure whether that's a good idea or not, but in the short term, this is how we coped, and the nurses were actually pleased with how it got on. The midazolam has gone back to 2.5 and maybe lower. The oxy is still up there at 5. And the wound doesn't smell anymore. And I don't know whether the metronidazole oral, which has been continued, should still be continued. Wayne provided us with the Prontosan wound dressing, which was a sample that we used with effect, and that was part of the helping get everything under control. But when that's run out, what should we be doing? And so we end up with these 2 questions. As the wound settles down, what can we pull back on? And I think they actually have pulled back on the lignocaine, which is good news. And how much does a rest home? How much are they obliged to pay for the Norspan, which was started in the hospital? The dressings, which I think they have to provide. I mean, Julia, there is no way of getting any of this subsidised. If there's a little bit of discussion about that. I think some people had their Norspan patch funded through WINS. We don't have a social worker amongst us, but I think that is an option. Is there anything else in that history that we need to clarify? This woman is still able just to get out in the car with a lot of help. Her mobility is very poor, but not really able to, all the consents really have been done through the daughter, who's not present at the dressings, to be honest. And she has, the patient's been a bit sleepy, a bit bombed after the dressings, but that's viewed as the cost of doing it. There was one other question that will come back to me. Yeah, if anybody wants to clarify some of that.
Thanks very much, Brian. So I'll just open it up to maybe we go to Julia first, because you probably know a bit about the case, if you wanted to add anything or if you had any questions or clarifications for Brian. We'll go on to recommendations in a moment.
I think that Brian's painted the clinical picture very well. I guess maybe what I could add is the conversations that I was having with the registered nurses, and just even how their own interactions together in terms of perhaps what the leadership was in the facility, and the practice, customer practice. You know, you get a group of nurses together and we'll all have, as doctors or any profession, we'll all have different ideas. But I think this is a prime example of how hospice could help lead with good examples of care, even though we're not completely 100%, I'll use the word confident, because it is a little bit of a guesstimation, as Brian's pointed out. But I think if we display our, you know, that it's a journey for us, and sometimes it's not everybody's the expert, and we can all learn from one another. And I think this has been a good example of that message, that we've come in and we've heard them and been there, and now that's been followed up. And as Brian says, the lignocane's been reducing, the order is less, and it's a shame really, because the facility had hoped to be present in ECHO this morning, but it'll be something that I'm very keen to keep a close eye on, to really work on those, you know, additionally to, well, maybe that's recommendations. Sorry, there's a cat wanting to get into the picture. Yeah, sorry.
Cool, thank you.
Yeah.
I just wonder if we go, well, just you, Robin, do you have any questions or clarifications at this stage?
I was wondering about Norspan. Now, I can't even remember what it is, but I think it's that old-fashioned antihypertensive, isn't it?
It's buprenorphine, Linda, or Temgesic as we used to know it.
Oh, Temgesic. Oh.
Yeah.
Why did you choose that when you've got all the other and cost you $30 a month, when you've got everything else available?
It was started in the hospital.
Oh, that's not a good reason.
But I've not interfered with it, and I'm not sure who's paying for it. The family may be paying for it, that they have very little money. I mean, it's equivalent to, I think, 7.5 milligrams of morphine a day. So it's a very small dose, and it's good in renal failure. And for this woman, it would be, I think, ideal if it was funded. But it's not. Yeah. So what else would we do? She does seem to need a little bit of long-acting opioid. Fentanyl patch is far too big for her. A little bit of long-acting oxy maybe. She seems to tolerate 5 milligrams. Yeah. I'm ducking the question a little bit. It seems to be working at the moment, and somehow somebody's paying for it.
Good.
The thing that I was also wanting just to put in front of the group was the ethics or the practicalities of actually us being able to watch this dressing done on an iPad, just to get an idea of how it's going and what it's doing, because she's an hour north of here, and it just seems a little like intrusive or the wrong thing to do. But I sometimes think that would be really useful, just to actually see how they do it. I mean, surgeons do it, don't they, remotely, with their remote surgery and stuff. And it was like, oh, are we allowed to do that? Would seem to be useful to me, but I don't know. I can drop that one in the mix as well.
Okay. Did anyone in the Hub team have any questions or clarifications?
Evie?
Yeah. I just wondered, one thing that's quite common in the community is family or loved ones saying, why do we have to do the dressing? It causes such pain. And whether that was an issue in this scenario and how you deal with that.
Yeah, it's not been an issue as far as I know. It would be nice to have an opinion as to whether this can be done every second day, and certainly taking it off in the shower every second day seemed to be a good idea. But I take your point, Debbie, that certainly can be a real struggle because we do painful things to people.
And I think it's easy for us to justify that there's benefit and reasons why we do it, but it can be hard for people without that medical understanding or background to know why we would subject their loved one to something that's causing them distress, because they can't see, you know, the goal that we're working towards as clearly.
Yeah, we will never cure this wound, which has sort of made me feel a little less worried about what we're putting into it.
Yeah. Okay. So I think we can move on to any recommendations or other comments about this patient. We might start with Robin this time. We'll unmute you. Did you have any recommendations or any comments, Robin, about the case?
Oh, far be it from me to recommend anything. I, like most doctors, keep as far away from the nitty-gritty of wounds as possible. And I'm always take my hat off to those who do these dressings. No, I'm just here to learn. I have nothing to add. Thank you very much. It's been most interesting.
Okay. Julia, did you have any comments, recommendations, suggestions?
I think this would be a great learning exemplar, because often we provide education in ARC and, you know, maybe the significance or the relevance of it to their everyday practice, even though we truly believe that education around palliative care and, you know, those sort of intricacies. But I think this will be a great way of building rapport and relationships with the facility, and maybe encouraging them to, as Debbie said, you know, to really think outside the box and have robust and good conversations with family around processes, so that maybe collaboratively together they could come to a decision that they can all agree upon. I guess, you know, wound care is something that you need to assess as you go along, and maybe the understanding that their protocol would change. So you've got them on board, and I guess that would be something that I'm hoping to continue. So that would be a recommendation from my perspective.
If you were teaching this, Julie, would you admit to putting chlorhexidine and lignocaine from a urinary catheter syringe into the wound?
No.
No.
No. But they need to have education around why, and I guess that's another element of this.
Yeah, it's been very difficult to get any other sort of lignocaine cheaply into the unit. It's very really complicated.
It is.
So I just had a thought about that. Maybe I should have thought about it when we were talking about it. Could we not do the same kind of thing as what we do with morphine and intrasite gel, and mix lignocaine into the intrasite gel and use that?
Yeah.
Yep. Do that. Yeah.
At least that way it's just the lignocaine, and we know that the gel is appropriate to be put into a wound. I've never ever done that before, but it would probably be better than the catheter lignocaine gel with chlorhexidine. And just, I know a long time ago I was asked to treat a wound with a chlorhexidine by a plastic surgeon, and it made a complete mess of the wound over a period of a couple of weeks. Yeah, so I definitely wouldn't do that.
Why did it do that?
I don't particularly know. It might have been a combination of the wound, but it was a chlorhexidine cream, and is on a lady's shin, and I had to get the surgeon, because she'd come and have the dressings done, and I had to go and find him one day because there was exposed bone in the bottom of the wound after 3 weeks of treatment. So just, and just like with sprinkling metronidazole tablets on a wound, I think if products aren't designed to be put on an open wound, we probably shouldn't be putting them onto an open wound.
Fair enough. Yeah. Any chance of doing this every second day, this sort of wound?
Yeah, so I was thinking about that, and that's usually for painful wounds in particular. It's one of the things that I would recommend that people try and reduce the frequency of dressings. So it would entail looking at the type of dressing you're using. So if there's quite a bit of exudate, you'd need to use something that's absorbent enough to contain the exudate. and then something on the outside that's going to stay in place, be gentle on the skin, and also have some absorbency. So for example, with this wound, I would probably suggest, I think we're using Aquacel or Durafiber in the wound. It's a very absorbent hydrofiber dressing. And on the outside, something like, what's it called? Meatpore?
Meatpore, yeah.
What's the one, it's the, it's got silicone adhesive, so it could be like a leave-in life, but the Mölnlycke one would be better. So it's got a silicone adhesive, so it sticks really well to the skin, but it's easy to remove and doesn't damage the skin. And it's got an absorbent foam in it as well. So if you gently pick the wound with the hydrofiber ribbon, you could put the gel on first, whether that's metronidazole or microdacin or prontosan gel, put the Meplex over the top, and you could leave it for 2 days. Because that also, the Meplex, Meplex, it is, has impermeable backing on it, so it also helps to seal any odour in as well.
So the rest home pays for this?
They would have to pay for it.
Yeah.
So that was the other thing I was thinking of. That's getting to be a slightly more expensive dressing, but then if you're only doing it every 2 days, you split the cost over the 2 days. And sometimes people don't get that, use a more expensive dressing, change it less often. The cost actually is not that much different. And plus you get better quality of life for the patient, resident.
And showering is definitely better for wounds that
Yeah. And just to gently shower the wound as well is quite good, as long as it's not painful, to help clean it and remove less debris.
Sort of got that buzzy bee analgesic-y sort of water thing going on as well.
Yeah, I think people tend to find things less painful, and particularly if, maybe not in this case, if you've got a patient who can take the dressing off themselves in the shower, so they can do it at their own pace and manage the uncomfortableness.
I do think there is evidence for the buzzy bee thing. I think it is that whole gated period of stimulating nerves proximal. I do think there's a role, maybe not in big wounds where you might need to, I think in terms of analgesia, you're talking about Norspan, if it's not doable from a funding perspective. We did have really good success, I know, with another elderly lady in residential care with necrotic feet wounds with really low dose methadone, so a milligram of methadone at night because of its long acting form as another option if you don't have other opioid choices. We talked about in the inpatient unit at one point looking at inhalational options, so nitrous or Penthrox, which I think are cost prohibitive really in the community, but in a hospital setting that's an option. And I know in general practice often in residential care we have people with quite isolated distal wounds, then regional techniques, so ring blocks into toes or fingers if people had ulcers that needed dressing. Similarly with topical analgesia, using morphine just in the wound, not having to give things systemically if we could get away with it. So I do think it's a real multidisciplinary approach and really good case like you've presented, where if we're talking collaboratively, every different member of the team has a different idea and they're all valid, instead of one person trying to just use their one area of expertise. Let's all contribute.
Right. Thanks. Did anyone else have any comments? We're kind of getting to the end of our time, but okay. Thank you very much, everyone, for your participation. Thank you, Brian, for presenting the case study. Quite an interesting one with actually quite a few different aspects to it, not just the wound. So that's good. Our next echo session at this stage is planned for the 20th of June. We have our presentation on that at that echo on diabetes management, palliative care. hope to have a few more participants and get a case study presented with someone outside of our team would be great. And if you do have a chance to do the evaluation form, that'd be really helpful for us as well. Otherwise, we'll see you on the 20th of June. Thanks again.
Thank you.
Thank you.